Professor Jaspreet SUKHIJA to present pharmacotherapy of myopia.
Very good morning, everyone. First of all, I'd like to thank Colonel Vaikar for this you can say a very wonderful IC where so many people are interested. I mean, it's the last day and it's a hot topic really because I mean, the mobiles are everywhere. The stress of near work. I mean, people just want to the amount of the competition which is there in India especially. So it's a lot of near work which is happening, and now gadgets which are coming up. So it's all being done on iPads, mobiles, children playing games. So a lot of issues coming up, and really it's becoming the next pandemic. So that's the reason we need to know how we can prevent the axial elongation of the eye so that you can prevent the complications which can occur later in life. So as is already been discussed, the methods to control myopia progression. So I have no financial interest in any part of this atropine which I'll be discussing. So the environmental modification very beautifully covered. You have pharmacological therapies which I'll be talking about, and then you have the optical corrections which again would be dealt with in another presentation. So basically what we have in pharmacological therapies here, what has been done over the years, what had been studied, so many trials have been done, is what we know as atropine eye drops. So they've been shown to be quite effective in slowing the myopia progression. However, we don't know the mechanism as well. They just proposed theories. It acts on the sclera and reduces its remodeling and elongation. It binds to acetylcholine receptors on amacrine cells. Obviously, really increase the dopamine release and inhibitory effect on the eye growth, or it could have an anti-inflammatory effect. So these things are not really clear because it's been effective in you can say chicks as well who do not have any accommodation. So the accommodation theory really doesn't hold true in that case. The other drugs under evaluation are just being discussed. Parinzapine, tropicamide, have seen no RCT is done. Then there are dopaminergic drugs where human studies are not available. Even in these anti-inflammatory drugs and IOP lowering drugs, we don't have any human data as yet. So what we have data for and which have been tried and tested and shown to be effective is atropine. Now the most common concentration which is used is 0.01%. That's widely available in the market. But there are trials which have been done with higher concentrations ranging from 0.025 to almost 1%. And what did they see? So basically, I'll be talking about 0.01% mainly, but I would cover the higher concentration as well. So most of the RCTs which have been done, if you see, this is the mean annual refraction and the axial length. So these are two things which are important when you deal with any case of myopia. So what happens is these circles are showing the number of patients who have been enrolled or number of trials which have been done. So if you see the atropine 0.01%, probably the maximum number of studies have been done, and this is the thicker line which shows so many trials have been done, the randomized studies have been done as compared to other concentration. And similarly is the case with the axial length. So most of our knowledge is about 0.01% atropine in preventing the progression of myopia. So how to select the concentration of atropine for clinical use? Well, it should be effective in slowing myopia progression. It should be well tolerated by the patients with least side effects, and of course should have minimal rebound on stopping treatment. So that's another important thing. So the first study was with 1% atropine. So it's a high concentration atropine. They had shown good efficacy, but the problem was this high dropout rate because of the side effects of photophobia. So everything is not just one direction. You have to see what are the side effects and how comfortable the child is. The other concentration, well, they lowered it then to 0.5, 0.25 and 0.1%. And this is again an RCT. So I haven't taken the studies where the RCT was there. Probably these are the important studies which have been done. So over a period of 2 years, they did show, you can say, a dose-dependent myopia progression decrease with the maximum in 0.5% as compared to 0.1%. So you can see just 0.04 versus 0.447. But the problem was the 22% side effect in the higher concentration group. So, and there was no placebo or axial length data in these studies. So probably it was not that important. So the ones which have been made a significant impact over a period of time are the ones which started with the first one in Singapore by Chia et al. That was the ATOM-2 study. Then the ATOM-3, you have the LAMP study, the CHAMP, and this is the Indian study done by the AIMS group. So where they shown a good effect with 0.01% atropine. So considering the progression of myopia on 0.01% atropine, because that's the most widely studied drug. So in the ATOM2 study, what they had was a rapid progression. So we would call it more than 0.75 diopters. That's almost 1 diopter. It was 18% in 2 years. And in the LAMP study, again, it was 28% in 1 year. So there's a lot of progression occurring despite using 0.01%. So in the Indian study, what really happened was at 2 years after starting atropine, the mild progression was seen 87.7%, moderate in 9.7%, and severe in 2.6%. So fairly worked well. And there was a 17.4% reduction in the rapid progressors with 2 years of atropine therapy. So rapid progressors, even those who are progressing more than 0.75 diopters, did have a reduction with 0.01% atropine. So why does lower concentration atropine work better for Asian children as compared to white children? Well, because of the studies what is shown, this is the conclusion what is happening. But why is it so? Because in Asian studies, what is happening is in our Asian children, you have darker iris. So atropine, what happens, binds to melanin. So we have a slower release and a long active time of the drug. And that is why it has a higher efficacy in Asian children who generally have darker irises. So that is why our studies have shown good outcome. The Western population has really not found a significant result with 0.01% atropine. So coming to the experience with higher concentration atropine, again, this is one of the important studies where they use different concentration. If you see 0.05%, they use 0.025, 0.01, and they had a placebo group. So whenever you have a placebo group, probably it's a good way to know the efficacy of each concentration that is working. So they gave it for 2 years, and the third year was a washout period. So what they found was that almost 79.4% children needed to restart the treatment, and it was the same in each group. So with the higher concentration versus the lower concentration, you can see it's about 80 to 85%, which is almost similar. And what they concluded was that this retreatment was associated with a younger age and not with the concentration which was used here. So if you have a 4-year-old child versus a 8-year-old child, that would make a difference, but not really what concentration you are using. So it was a dose-dependent effect in each age group. So when they saw it, then this basically 0.05% was the most effective as compared to 0.01% in slowing the refractive progression, in decreasing the progression of the axial length. And it had a good tolerance over 5 years because they used it over 5 years. And they said that it should be continued for 5 years and did not find any difference in accommodative amplitude or a decrease in photopic mesopic pupil size or a dilated pupil, which was same in all the group. The problem was that it did not measure the rebound. So it's an ongoing study, but we don't know what would happen if the 0.05% atropine was stopped. Would the children go back or to the previous levels? What would happen? Or there would be sudden increase in the axial length. So if they compared the 0.01 and 0.05, no doubt it was much more effective. So 67% slowing, axial length 51% slowing, but the problem was photophobia. If you see 7.8%, so that is a problem coming up with 0.05%. So if you see another study where they compared again 0.01%, 0.1 and 0.5%. So they gave it for 2 years. Now these darker areas, if you see, these are the ones where you have a higher refractive error. So what they did, they gave these concentration atropine drops with different concentration for 2 years, and in year 3, so this is that year where they stopped everything. Now what happens is, in the 0.5%, what happens, if you see, this is the high refractive error. So you have the maximum here, almost similar here, but the least in 0.01%. So considering that because there was a greater rebound effect with the higher concentration, they started 0.01% in all the 3 groups. So when they restart 0.01% in all the 3 groups, what they found was those who had initially 0.01%, so this group, if you see this group, you can see the refractive error, high refractive error much less as compared to this and this. And so they concluded that 0.01% is clinically more palatable. So rebound has to be considered in case of every kind of treatment you are giving, because you're going to stop it at some time or the other. So basically, this is the latest study which has come up with the 0.05%. It's a higher concentration, and they did find a significant reduction in myopia progression, a significant reduction in axial length progression as well, but there was no correlation between the axial length and the spherical equivalent. And here they had a different conclusion that the response to treatment was independent of the age, whereas the LAMP study said that the age was the most important criteria. And this study, they did not find any side effects. This is again another study using 0.05%. So these are higher concentration studies, which are very few. So I've just put in just to show you what they found over a period of 2 years. Of course, just finish it. Yeah. So basically, atropine given after 2 years of placebo, the effect of age could have a role in decreasing myopia progression, because they started after seeing that there was a progression for 2 years. They were giving placebo, but didn't work. They gave the higher concentration. So they had tolerable side effects. Rebound not studied. The meta-analysis is a big meta-analysis. Basically, that recommends 0.01% using to reduce the progression of myopia, because the side effects they were not were much higher with the 0.05%. And then the WHO also has their recommendations for 0.01% for 2 years. If you have good response, they say taper and stop. If it's a moderate response, that is between 0.5 to 1 diopters, you continue for 1 to 2 years. Well, if there's a poor response, that may be a response non-responder, and consider alternate treatment. So those are the WHO guidelines for 0.01% as well. So coming to the end of my presentation, just a brief, so much confusion about the concentrations. Everybody must be thinking, what is the ideal concentration of atropine to be used? Well, you have higher concentrations, no doubt they are very effective, 1%, 0.5%. But the problem is bothersome side effects and the high rate of rebound myopia. If you go to lower concentration, this has tolerable side effects, 0.05, which is being used in many studies now, but data on the rebound myopia is still not available. So that is again very important. So till date, what really is 0.05%, which has been used. It is the most effective concentration at 5 years, which has been shown, least rate of rebound myopia, and minimal side effects. So the efficiency of atropine is dose dependent, but the side effects and the rebound are still need more studies to know actually where we are going about. So how to taper atropine? Well, there are no guidelines. You could just do it. You use for alternate days for 3 months, maybe once a week for the 3 months. But remember, we are more concerned in younger children and fast progressors. So every case would be dealt differently. So I'd like to conclude here by saying that 0.01% is the only approved drug for myopia control. It's a well-researched drug. Side effects are negligible, works well in the Asian population, is cost-effective, no significant rebound. Of course, you need customization for poor responders to 0.01%. Could need higher concentration or maybe use alternative form of therapy. Yes, higher concentration definitely required for younger children. But yes, remember, we need the rebound what is happening, and there are of course issues with side effects as well. Thank you.
Thank you, Professor